I have many people to thank for being here. It's quite an honor, Dr. Hanna first, and the Kingdom of Bahrain. I am a psychiatrist at the Embassy of the United States in Bahrain. I'm a guest here, and I'm grateful to be here. I'm not a rheumatologist, and so I'm going to talk about stress, anxiety, and depression as a possible cause of rheumatological disorders. And so this causes me a little stress and anxiety. It's a complicated subject, rheumatology, that has evolved considerably since I studied it in medical school. And I must admit that when Dr. Emil Hanna suggested that I talk on this subject and consider this question, I believe now that I got the answer wrong initially. It's an important question, I think, is there a causal relationship? Can you say that a physical condition, rheumatoid arthritis, fibromyalgia, certainly in the realm of rheumatology, can you say that one of the things that causes it is psychological stress, anxiety, depression, these mental conditions? Can they actually lead to a physical result? And I think that we'll be able to explore that through looking at the relationship between these by making definitions very clear about what we're talking about when we talk about psychological conditions and what we're talking about physical conditions. In the end, I'm sure that everyone here knows that there will be a complex relationship between physical conditions such as stress, anxiety, and depression, and physical conditions such as fibromyalgia, rheumatoid arthritis, that it may not be clear which is causing which. This slide it describes a segment of the field of psychoneuroimmunology, and this is the proposed connection between the mind and the immune system, the psyche, and its effect through the brain on the immune system. And just to summarize, we'll come back to this slide again, but just to summarize, there are stressors that you might consider as possible influences on the immune system. Physical stress and psychological stress are both possible contributors. And they do have powerful effects, as been shown in many preclinical studies. Both physical stress and psychological stress have powerful effects on the immune system. The effects are better understood in laboratory settings with animals and such, because it's just not ethical to apply significant psychological or physical stress to humans. The preclinical information overall exceeds what we have as far as clinical results. We know that there are many effects. We're not sure exactly which ones are the most important. But the effects of psychological stress on the mind certainly affect the brain, and there are direct neurochemical effects in the neurochemical functioning of the brain that can be detected through levels of neurotransmitters, through functional neuroimaging studies. There are immunological effects that clearly follow psychological stress, either acute or chronic. There are neuroendocrine effects. The most well-known and well-established, long-established effect is a change, a suppression in the HPA axis with CRH, ACTH, and cortisol decreasing. And last but not least, there are behavioral effects that respond to psychological stress. And this may actually be the most profound way that psychological stress leads to a change in the immune system. Because psychological stress leads to changes in sleep, activity, all sorts of activities. Psychological stress leads to a change in how we take care of ourselves, how we reach for those basic things that restore ourselves physically, what we eat, how long we sleep, whether we exercise or not, whether we rest our ailing bodies when we need to, whether we take the medication that was prescribed to us or choose to take something else or nothing. Psychological stress has behavioral effects, and this may be the most profound way that the immune system is affected. Now, physical stress has similar pathways in some cases to psychological stress in the way that it affects the immune system. And the amazing thing, and unfortunate for our question, is that physical stress leads to changes in our bodily function that then affect the brain and can lead to mental problems as well. So the arrows go both ways. The physical stress can lead to changes in the immune system. Psychological can as well. And physical stress can lead to changes in the mental system. It's a psychological stress in itself. Now, psychological conditions are, in their modern definition, the attempt has been made to, in a blanket fashion, describe them acausally. They are not described in terms of what their origins are. They are described in terms of how much distress and disability they cause and what kind they cause. So if you look at the Diagnostic and Statistical Manual of the American Psychiatric Association, which has become a handbook and worldwide definition to some degree of what mental disorders exist and what don't, you will find a list of, a collection of checklists, basically. And the checklists say, this is this syndrome, this is that syndrome. So they are syndromes. A syndrome is basically a checklist, a collection of signs, symptoms, laboratory values, whatever. And they are functional. That is, they are determined by distress and disability rather than laboratory findings. Now, there are fairly robust laboratory findings that are associated with certain mental diseases. Post-traumatic stress disorder is associated with hypoactivity of function in the hippocampus, this area of the brain important in forming memories. It's associated with smaller hippocampi. But if someone has symptoms of post-traumatic stress disorder and they have nice big hippocampi, then they still have post-traumatic stress disorder. It's irrelevant to the diagnosis, or the definition, I should say. It's irrelevant to the definition. Stress, one definition is an experience of distress, feeling preoccupied, easily startled, fearful. These would be subjective, I'm like this. And disability, that is what others might notice in terms of irritability, that the patient can't sleep well, has poor concentration, poor self-care, and all these sorts of things. Depression, in the same way, it's 5 out of 9 symptoms. It's low mood most of the time, combined with loss of interests in pleasurable activities, poor concentration, suicidal thoughts, low appetite, sleep disturbance, energy problems. I don't think I've gotten all 9, but that's not important. It's a checklist. It's a functional syndrome. Anxiety is another functional syndrome. Now, these are very powerful tools, syndromes. They allow us to define a disorder, and until you define a disorder, you can't research it, you can't treat it, you can't prognosticate. But syndromal diagnosis has some difficulties, but I'm getting ahead of myself a little bit. Let me come back. There are physical conditions that are syndromes. Fibromyalgia is one. It has widespread pain, sleep problems, and cognitive problems. That's actually the American College of Rheumatology's most recent definition. There was a previous definition of fibromyalgia that involved specific tender points. And I imagine that that's still operative at this time. But regardless, this is a syndrome. This is a functional syndrome, actually. Now, rheumatoid arthritis. Is rheumatoid arthritis a functional syndrome? Yes, it's a functional syndrome because it's a syndrome. It's defined according to a checklist, right? You have lab findings, serologic parameters, duration of arthritis, objectively assessed joint involvement. Now, a functional syndrome is a syndrome that is defined by distress and disability. Does distress and disability alone define the disease of rheumatoid arthritis? If I say my joints hurt, but you don't see a red or swollen joint, if my lab values are normal, do I have rheumatoid arthritis? No. So rheumatoid arthritis actually is not a functional syndrome. It's not defined by distress and disability. Now, it's associated with distress and disability. In fact, distress and disability may be a component of the diagnosis, such as morning stiffness. This is a functional symptom. This is not a physical finding or a laboratory value. But rheumatoid arthritis is not a functional syndrome. And this is an important distinction. When you're working with an individual with one diagnosis or another, it's important to establish if they have a functional syndrome or if they have some other sort of disease entity. Because the way you manage these has to be different. Now, functional somatic syndrome is a physical condition that is a functional syndrome. And I know this is a little bit picky getting into this, but I think you'll see how it's important in the next few slides. So fibromyalgia, some would argue that fibromyalgia is not a functional syndrome either. That fibromyalgia is a disease entity defined by things other than distress and disability. However, that is not an element in its diagnosis. There are findings such as HPA axis dysfunction or human growth hormone dysfunction in fibromyalgia patients. What there are not is findings which show that this makes one have fibromyalgia or not have fibromyalgia. The distinction of having fibromyalgia or not having fibromyalgia is whether you have widespread pain, cognitive disturbance, non-restorative sleep. That is fibromyalgia. Now, one trouble with making the diagnosis of a functional syndrome rather than a disease entity is that functional syndromes tend to blur into one another. So if someone has chronic stress, which is not in the DSM, but a well-known, measurable type of suffering, that person is liable to have, say, poor sleep. And persons who have depression and anxiety also have poor sleep. Now, the person with chronic stress or anxiety may be much less likely to have suicidal thoughts. They might have suicidal thoughts, but they'd be much less likely than an individual with depression. The person with depression would be more likely to have hypersomnia, to sleep too much. But functional syndromes, and these are the psychological functional syndromes that we're talking about, blur into one another. Now, there are also functional somatic syndromes that blur into one another. Fibromyalgia is one, multiple chemical sensitivity and chronic fatigue syndrome. It's hard to know in a given patient which one of these syndromes best describes their experience and their suffering. And whether someone ends up with, say, chronic fatigue syndrome or fibromyalgia might be determined by whether they visit a rheumatologist first or an infectious disease specialist first. It might be determined by which web page they read or which friend they spoke to first. And to distinguish these disorders from one another is very difficult. In fact, distinguishing fibromyalgia from chronic stress, depression, and anxiety is very difficult to do. Now, there are some physical findings in fibromyalgia, such as disturbance of the adrenocortical, of the HPA axis, but these findings are also found in depression and anxiety. There are physical complaints in fibromyalgia, and it's part of the definition, but anxiety disorders are famous for causing headaches, as is depression and chronic stress. So it's difficult to separate fibromyalgia from these. So we're in a difficult situation when we ask a question, can stress, anxiety, and depression cause fibromyalgia? Because we can't completely say that they are different entities. They're part of the same thing. So, does a sunny day cause a sunny day? How can you answer that question? Now, what about rheumatoid arthritis? There are aspects of the definition of rheumatoid arthritis that are completely distinct from the functional disorders, chronic stress, depression, and anxiety. The laboratory findings in rheumatoid arthritis are quite robust, and they're part of the definition. And so in this case, we need a different approach. And we could actually pose this question in a way that we couldn't before for these other disorders. Does depression, anxiety, stress, can it cause rheumatoid arthritis? Now, this is just a very small sampling of a literature that I think there are probably about 50 people in this room that know better than I, that looks at the connection between rheumatoid arthritis and then mental conditions such as stress, anxiety, and depression. And there is clearly a tight association between rheumatoid arthritis and these three conditions. And just to walk through it, we know from various sources that psychological stress affects immune function and could be posited to cause rheumatoid arthritis through that. That rheumatoid arthritis patients report a higher rate of childhood emotional neglect and physical neglect than controls. That psychological stress is associated with rheumatoid arthritis flares and with a poor prognosis in rheumatoid arthritis. And that depression and anxiety are common in RA. In fact, it's more common than not that an individual with rheumatoid arthritis has a diagnosable disorder such as major depression or generalized anxiety or the like. So we know that there's a strong association. Now, do any of these predict causality? Do any of these associations predict causality? Let's take, for example, an individual who has major depressive disorder and rheumatoid arthritis. Is the major depression causing the rheumatoid arthritis, or is the rheumatoid arthritis causing the depression? We don't. Which one? That is, on the face of it, so evident that if you had rheumatoid arthritis, it would make you sad. And it could well be causing depression. And the other argument that depression is creating some kind of inflammatory cascade is a little more tenuous, wouldn't you say? it's a complex relation, so we don't know. I think that is my answer, that we would suspect that the depression is due to the RA. However, we must admit that the interaction goes both ways, and we don't know which came first. We don't know which is causing which. Now, how about higher rates of childhood emotional neglect and physical neglect in rheumatoid arthritis? Is the childhood emotional and physical neglect causing the rheumatoid arthritis, or is the rheumatoid arthritis causing the childhood and physical neglect? I think that one can only go one direction, because the rheumatoid arthritis comes much later than the childhood emotional and physical neglect. So I think this is a relatively strong finding to suggest that to some degree, depression, anxiety, these kinds of things, chronic stress, may be causing rheumatoid arthritis, increasing the risk of diagnosis, somehow causing that. Now, this is all very, very interesting, but what we'd really like to see, I think, to establish the connection and make it actually worthwhile is say, hey, we took some people with chronic stress and rheumatoid arthritis, and we treated their chronic stress, and their rheumatoid arthritis got better. That's what we all want to see, right? Who cares what caused it in the first place? Can we treat rheumatoid arthritis by treating stress? And there is some data coming forth suggesting that these interventions, you might call them mind-body interventions, can actually have meaningful clinical effects on patients with rheumatoid arthritis and other disorders that may actually exceed the element of their disorder that's functional. Now, I would argue that you should treat any functional syndrome with mind-body medicine, but these non-functional disorders, these disease entities, these biological disease entities, we should also consider. Now, this study looked at 74 rheumatoid arthritis patients and assigned them in a randomized fashion to two branches. One was several weeks of stress management training, where they learned relaxation techniques, how to make themselves calmer, more peaceful, happier. And the control group received basically nothing. And then they followed them up at baseline, at 1 week post-training, and at 9 weeks post-training. And they used a psychological stress test to assess the individual's response to stress. And they measured three things: subjective distress. They measured a marker of autonomic nervous system activity, alpha amylase, and they measured cortisol, which, as you know, is the main stress response hormone. And they had interesting results. This graph shows the outcomes at 1 week after the stress management training program, and then at 9 weeks after the stress management training program. The red bars are the intervention group, the ones that actually received training, and the blue bars are the ones that did not receive stress training. And they followed them at time 0. They followed them through this stress test, which, by the way, is a simulated job interview. They could also have them speak to a large group of intelligent people. That's kind of stressful too. Job interview, they asked them to do math. They looked at them with stony faces. They gave them a bad time generally for about 15 minutes. And they found that in both groups, the subjective stress, as measured by a visual analog scale, increased and then decreased, and there was really no difference between these two groups. Neither was there much of a difference between the autonomic nervous system activation as they were able to measure it. But when they measured cortisol, they found that baseline cortisol levels were lower in the individuals who had received the stress management training. And this was present at both 1 week post-treatment and 9 weeks. And they also found that they had less of a cortisol response to this intervention. And in the end, I think this data shows that this doesn't do what I would hope to see, which is we made their rheumatoid arthritis better by doing this intervention. I don't know if anyone's been able to do that. But what people have been able to show is that markers of inflammation can be reduced. They've been able to show in other studies that functional capacity and feelings of well-being can be improved. And it may be, since we can show that there's an effect on the immune system with these mind-body interventions, it may be that in the future these can become somewhat of a standard for our practice and package that we provide to individuals with chronic illness. And I think actually that mind-body medicine or psychological medicine, psychosomatic medicine, whatever you want to call it, is something that should be to some degree part of your practice now, certainly for patients with functional disorders where distress and disability is exactly what you are targeting, but also for individuals with physical ailments that go beyond functional, that have these biological markers involved as well. And you may not have access or patient willingness to participate in stress management classes, or they may accept a referral to your colleague, Dr. Tariq Madawi, a fine psychiatrist who collaborates at the International Hospital, or they may not. Patients are reluctant to see psychiatrists by and large. But you can practice good psychological medicine with them and enhance the effect of your biological treatments by the element of psychological medicine that merely comes from your person. It's very easy as a doctor to underestimate how terribly important you are to your patients, how important it is that you have fondness for them and have concern, that you admire them and respect them. It's easy to forget that you're important to your patients because every single day you prescribe patients medications and they go home and don't take them. And it gives you the sense that you're not as important as you really are. But patients spend weeks thinking about their appointment with you. They hang on your word. They rehearse what you said after you left. Your very person is a powerful influence on them and through that their health. So here's a 3 minutes or less intervention that you can do that's good psychological medicine to add to your physical medicine. Am I over time? I'm okay. The first is to know your patient. Listen to them, know their concerns, and also know them as a person. One study looking at medication adherence found that the single most important element in that study that they could find that was associated with patient adherence was not anything about the patients or the doctors, but the answer to one question that they gave the patient, which is, does your doctor know you as a person? The patients that said yes were remarkably adherent to their medications, and the patients who said no didn't take them. So know your patient. Know your patient. Listen to them. Listen to their concerns. Certainly listen to their physical concerns. If they're concerned about the weather, listen to that too. Just listen to your patients. Reflect back what you know to your patient so they know that you know them. Declare an alliance and express hope and optimism. So you might say something like, Mrs. Jones, you have a new diagnosis of RA. I hear your concern that it's untreatable, unstoppable, and it will take your life. So you know that person. You've shown that you know that person. Well, not if I can help it. Declaring an alliance. You and I, we've got a lot of ways to treat RA, so when we get your medications tuned up, you're going to feel a whole lot better. Hope. And you should know this, most of my patients with RA are doing just fine. optimism. That's where you want to be with your patients to practice good psychological medicine. The unfortunate thing is that good psychological medicine is often difficult to practice while you are trying to practice good physical medicine. So good physical medicine dictates that if your patient is non-compliant with their medications, they need a scolding. But good psychological medicine is expressing your respect and admiration, and it's hard to do that and scold someone at the same time. You want to pick something to praise. You want your overall interactions with your patients to be positive, even when they're not doing what you want them to. A patient with a poor prognosis requires education, and it's one of the most precious things we can give to our patients. But at the same time, optimism, anticipation for positive things in the future, hope, are things that you must include. It's often difficult when working with a patient with a chronic illness to be hopeful. How can you be hopeful with someone who is at the end of their life with a chronic illness? I think it's easy to look at that person and think that there's nothing to be hopeful for. But someone who is at the end of their life with a chronic illness can hope for a good day. They can hope for a comfortable day that they can spend with family. They can hope that they'll have time to say things to loved ones that they wanted to. Everyone can hope for something. So find that thing. You must support disability. You must document and certify the disability that your patients have so that they can get wheelchairs or nursing home placement or things like that. But at the same time, you must expect from them all that they can give, all that they can offer. So you have to be, at one point, the person who signs the wheelchair certificate, and then immediately following, you have to be the cheerleader who advises them to go on a walk. And if the patient has low self-esteem, you might suspect major depressive disorder, for which you'd prescribe medications, make a referral, make a diagnosis, let them know that they have another dread disorder on top of their rheumatoid arthritis. But at the same time, you want to say, you and me together, we're going to beat this. That's where you want to be with your patients. So that's good psychological medicine. So in conclusion, the answer is yes. And I put the question down again in case you forgot. Stress and anxiety, like most answers in the medical literature, it's not 100% Loctite. But stress, anxiety, and depression seem to cause rheumatologic disorders. In the case of fibromyalgia, it begs the question to ask if they cause the disorder. Since these are the fibromyalgia and these conditions are in a continuum of functional distress and disability. Rheumatoid arthritis, there is some evidence suggesting that psychological stress is one factor causing rheumatoid arthritis, and considerable evidence that stress, anxiety, and depression worsen the symptoms and disease course of rheumatoid arthritis. And the clinical implications of this are that you should practice good psychological medicine and consider at least a brief psychological treatment for all your patients. Thank you.